Welcome to the deep dive. Our mission here is pretty straightforward. We take a specific source, unpack the key knowledge and insights, and deliver it straight to you, the practicing neurologist. Just a reminder, this is strictly for educational purposes. There's no commercial goal here. What we discuss is really just a summary of the information in the source. We definitely recommend you read the full paper for all the details and the complete context. So today we're diving into a recent multicenter cohort study. It was published in Neurology, Neuroimmunology and Neuroinflammation in 2025 by Siri and colleagues. The focus is rituximab use for relapse prevention in adults with anti-NMDA receptor antibody-mediated encephalitis. And it's important we say upfront, this paper provides class 4 evidence on the topic.
Right. Let's get into how they set this up. The study looked at 67 adult patients, so 18 years or older. They were drawn from 10 different hospitals across Australia. Diagnosis was, typically based on the clinical phenotype and, crucially, detecting those anti-NMDAR antibodies in the cerebrospinal fluid.
And the data collection, mostly retrospective.
Primarily retrospective, yes, from medical records, though they did include some patients prospectively. They gathered quite a bit of information. Demographics, the acute clinical features, lab results, CSF, MRI findings, immunotherapy timing, and outcome scores like the modified Rankin scale, the MRS, and case scores.
How did they analyze the rituximab effect specifically?
They used Cox proportional hazard models, which is, pretty standard for this type of time-to-event analysis. Rituximab exposure was treated as a time-varying covariate, so the model accounts for whether a patient was considered exposed to rituximab at any given point in time.
And how did they define a course of rituximab?
They defined a single course fairly broadly, actually. It included various dosing regimens that patients might have received. They also set up 2 specific models to explore how long the effect might last, which is relevant for thinking about redosing. One model assumed the effect lasted 6 months after the last infusion. The other assumed 12 months.
Okay. And relapse itself, how is that defined?
Relapse was defined clinically. Basically, new or worsening neurological features after the patient had been stable or improving for at least 2 months.
Got it. Let's talk about the patients themselves. What did the cohort look like?
The median age at onset was around 27 years, and it was predominantly female, 78% of the patients. Common features in the acute phase were quite broad. Cognitive symptoms were seen in 91%, psychiatric in 96%, seizures in 63%, movement disorders in 57%, and about half, 52%, had disturbances of consciousness.
Was there a high rate of associated tumors?
Ovarian teratomas were found and removed in 19%. Overall, tumors were present in about 25% of the cohort. And critically for those tested, 100%, so 65 out of 65 patients with CSF tested, were positive for the anti-NMDAR antibodies in the cerebrospinal fluid.
What about the timing of treatments?
The median time from when symptoms started to getting first-line immunotherapy was 30 days. Getting rituximab took a bit longer, a median of 58 days from symptom onset.
What is severity and recovery?
In terms of severity, the median worst MRS score, the nadir, was 4. That indicates, severe disability. But the recovery picture was better. At 12 months, 75% of patients had an MRS score of 2 or less, meaning slight or no significant disability, able to manage their own affairs.
So despite that initial severity, a good proportion achieved pretty good functional outcomes. But the key question is relapse. What did they find there?
Right. Over a median follow-up of 45 months, which is a decent period, 28% of patients had at least one relapse.
Almost a third. And the timing of that first relapse?
The median time from their initial hospital admission to the first relapse was quite long, actually, 764 days.
Over 2 years on average. Were there clear differences between those who relapsed and those who didn't?
Yes, and this is a really interesting part of the study. Patients who relapsed had a significantly longer time from symptom onset to receiving their first-line immunotherapy.
How much longer?
The median was 76 days for those who relapsed, compared to just 18 days for those who didn't. That difference was statistically significant, p-value below 0.01.
Wow, that's a substantial difference, more than 2 months longer on average?
It is. And similarly, the time from symptom onset to getting rituximab was also significantly longer in the relapsing group. Median of 156 days versus 35 days in the non-relapsing group. That p-value was 0.003.
So delays in getting both first-line and second-line treatment seem linked to relapse risk here.
Exactly. They noted that initial treatment delay defined as beyond 30 days was much more common in patients who relapsed. 79% of them had delayed treatment versus 47% of non-relapsers. Again, statistically significant, p below 0.01.
That really underscores the need for prompt diagnosis and treatment initiation.
It strongly suggests that, yes. They also looked at maintenance IVIG. It was used more often in the group that relapsed 58% versus 15%.
That seems counterintuitive.
Well, they did a post hoc analysis and found that most of the relapsing patients who got maintenance IVIG actually relapsed after they stopped it. So it raises questions. Maybe it wasn't preventing relapse effectively in those individuals, or maybe stopping it triggered the relapse. Hard to say definitively from this observational data.
Okay, let's focus now on the main event, the impact of rituximab itself on relapse risk.
Right. So they ran a multivariable analysis on 51 patients. This adjusted for things like other immunotherapies, including IVIG and whether an ovarian teratoma was present. And they found that receiving a single course of rituximab was associated with a significantly longer time to first relapse.
How significant?
The hazard ratio was 0.11, the 95% confidence interval was 0.02 to 0.70, and the p-value was 0.02.
A hazard ratio of 0.111, that translates to roughly an 89% reduction in the hazard or risk of relapse at any given time point for those who got a single course compared to those who didn't in this model.
Correct. An 89% reduction in relapse risk associated with that single course. It's quite a strong association found in this data set.
That does sound substantial, suggesting maybe one course could be enough for some patients.
Well, this data certainly provides support for considering that, yes.
Yeah.
Especially perhaps in patients who've had a good recovery or maybe milder initial disease.
But what about redosing? What did the duration modeling suggest? That seems key if you're considering ongoing treatment.
They looked at this in 66 patients. In the model that assumed the rituximab effect lasts for 6 months after the last infusion, rituximab use was significantly associated with a longer time to relapse. The hazard ratio there was 0.05. Confidence interval was below 0.01 up to 0.48, and the p-value 0.005. They used penalized likelihood for this analysis, likely because there were very few or zero relapses in the rituximab-exposed group during that 6-month window.
So protective associations seen in the 6-month window model, what about the 12-month assumption?
When they assumed the effect lasted 12 months, that statistically significant protective association was lost. The hazard ratio was 0.60, confidence interval 0.15 to 2.4, and the p-value was 0.47. The confidence interval crosses 1, indicating no significant difference.
Interesting. So based purely on this modeling, the protective signal seems stronger or perhaps only clearly evident within that 6-month time frame post-infusion.
That's what this specific analysis suggests, yes. If you're thinking about redosing based on maintaining a protective effect, this data points more towards a 6-monthly interval than, say, a yearly one.
Okay, let's try to synthesize this. What are the key practical takeaways for neurologists listening based on this deep dive into the SERI paper?
I think there are a few key points. First, that finding about a single course being associated with that 89% reduction in relapse risk is quite compelling. It provides observational evidence supporting the use of a single course, which might be sufficient protection for many patients.
Particularly those doing well after the acute phase.
Exactly. Second, for patients where you are considering redosing, perhaps due to ongoing concerns or disease severity, this study's duration analysis suggests a 6-monthly interval might be more effective at delaying relapses than less frequent dosing, like yearly. It seemed to push relapse out by about 6 months post-administration.
And the third key point.
We have to come back to the treatment delay issue. The finding that delayed first-line and delayed rituximab initiation were both linked to higher relapse risk really reinforces how crucial PrOP treatment is in this condition.
Absolutely. Now, we mentioned class 4 evidence. We should also touch on the limitations the authors themselves highlighted. What were the main ones?
Well, as class 4 evidence, it's primarily retrospective and observational. So you can't definitively prove cause and effect, and there's potential for bias. The sample size, 67 patients, is relatively modest. Follow-up times varied. The clinical definition of relapse can have its limitations. There's potential indication bias. Maybe sicker patients were more likely to get rituximab, which could confound the results, so they tried to adjust for some factors.
Any other key limitations?
They didn't have data on peripheral lymphocyte counts, so B-cell depletion status wasn't factored in. They couldn't fully adjust for the specific doses or timing of all the other concurrent therapies people received. And importantly, they didn't collect data on adverse effects for this study.
Right. Important context. So wrapping this up then, this deep dive into SERI and colleagues' study gives us some useful data points for managing anti-NMDAR antibody-mediated encephalitis. It suggests, with the caveats of class 4 evidence, that a single rituximab course is associated with a significant relapse risk reduction, potentially enough for many. For redosing considerations, the data leans towards a 6-monthly interval being associated with better relapse delay than less frequent dosing. But perhaps the most consistent signal, alongside the potential benefit of rituximab, is the strong association between delayed initial immunotherapy, both first-line and rituximab, and a higher risk of relapse. Which brings us to a final thought for you to consider in your practice. Given this evidence linking delays to worse outcomes, beyond just choosing the right drug, how can we systematically improve the speed of diagnosis and treatment initiation, getting both first-line therapies and agents like rituximab started promptly for these patients? What are the barriers in our systems, and how can we overcome them?
And just to reiterate, this has been a summary for educational purposes. Please do consult the full paper for all the detailed information and the author's complete discussion.